Hi everyone, it's Shelley with 50 Up Health and Beauty, and welcome to another segment of my expert series. Now, if you've been following me, you know that before I started this channel, I spent over 17 years in psychiatry. And during that time, I had the privilege of bringing world-class speakers to the clinical community in Los Angeles. But one of my absolute favorites and a true global leader in the field of psychiatry is joining me today. Dr. Roger McIntyre is the professor of psychiatry and pharmacology at the University of Toronto, and he's also the head of the mood disorders Psycha pharmacology unit. And today, we're tackling a question so many of us in the 50 Up community face. And that is this forgetfulness just normal aging, or is it something more? Now, Doctor and I will be discussing how to protect your mental sharpness and the unique ways bipolar presents after 50, and the cutting edge research Dr. McIntyre is leading to help us stay at our best. So please welcome Dr. Roger McIntyre. Dr. McIntyre, I am so happy to see you, and I really appreciate you taking time out today to be on 50 Up Health and Beauty. You know, you and I worked together, and during that time period, we really focused on bipolar depression.
We did.
And during that time, I really thought that most people got diagnosed with bipolar around 20 years old and they started to see symptoms. But after doing research to prepare for this talk, I kind of saw that that's not really true, that patients can actually get diagnosed later in life. Can you talk a little bit about that and what it looks like?
Absolutely. Before I do, on a personal note, nice to be with you and
Yeah.
nice to do this together. And remember fondly our times working together. Now that we, just like I guess, a rock and roll band, we call this the reunion tour. We'll call it that.
Right.
How's that? Okay. Look, I think that your point is well taken. And I think that part of your assumption is very understandable because we tend to talk about bipolar disorder as though it's a sort of a single monolithic organism, sort of a single entity. But in fact, it is a group of disorders. It's a group of entities. There's many different conditions that we call as one category bipolar disorder. And they're all very different with respect to how people experience the illness. What are some of the most difficult symptoms? What are some of the treatments that help people? But specifically to your question, the age at onset. It is true that the majority of people, what's the majority? Not 51%, but more than 75 to 85% of people who have bipolar disorder, who live with the illness, do declare the illness before the age of 25. Notice I didn't say 100%. I said about 75 to 85%.
Right.
So one can do the quick mathematics. That means the remainder is at some other age. And there has now been replicated evidence that a not insignificant percentage, close to 10%, maybe a bit more, depends on the study, of people with bipolar, for the very first time, they have the illness after the age of 50. To be clear, these are not folks who had the illness at age 20 who grew older, now they're 55 and have it. These are people, for all sakes and purposes, there was no evidence whatsoever of having a bipolar disorder, and then at age 50 plus, it does in fact manifest. I will say though, if I can say this, we call that old age bipolar disorder. I think it's a terrible name. There's no reason why people who are 50 and older are called old age. It doesn't matter. But we call it old age bipolar. So it's a terrible, terrible name. But it can manifest after the age of 50. That is for sure.
How does this the cause of it, how is it different from a 20-year-old to a 55-year-old?
It differs in ways that are very significant. And again, it's a reminder that these are a group of disorders. One of the aspects about clinical psychiatry that I have informed clinicians all over the world is that if someone comes into your office and they're struggling, for example, with depression, what we have learned, not just from experience, but from really a mountain of evidence, is that the best determinant of whether or not that person has bipolar disorder is, do they have a family history of bipolar disorder? Now, most people that I meet, I've done this for a long time, more than 30 years collectively, including all my training. Most people I meet with bipolar do not have a family history, just to be clear. But family history is the best predictor of whether someone who has depression is going to eventually have bipolar disorder. And when we sit down with people who have their illness begin around, say, 20, 25, we're more likely to hear about a family history of mental illness like bipolar disorder. People who have an agent onset of bipolar after age 50, they more often do not have a family history of bipolar or any other mental illness. That's interesting. So they don't typically have the same degree of what we call penetration of the family with mental illness. The second part of the story, which gives some hint as to what might be causing it, there's been some really interesting data to show that if people have a later agent onset of bipolar, in addition to having a lower probability of a family history of bipolar, they have a higher probability of having medical conditions, and specifically medical conditions that affect their vascular health. In other words, more likely to have strokes or more likely to have events which are sort of related to strokes called TIAs. Mm-hmm. And there's been really a long history. It's sort of long been known that in the field that people whose agent onset of bipolar is later, for example, after age 50, if they go for an MRI scan for, let's say, some other, you wouldn't go for an MRI scan to diagnose bipolar. But let's say you go to an MRI, you got a bad headache, you've had head trauma or something, whatever. You go for an MRI scan. So now it's on the record, you have an MRI scan. Some very thoughtful researchers have gone back and dug up those MRI scans, the people who had them done for one reason or the other. Or in some cases, it's just researchers at universities or academic centers who are doing a research study where they identify, say, 10, 20, or 30 people with bipolar agent onset over 50. What they find is a higher rate of vascular disease in the brain. Mm-hmm. And all that's to say is that does suggest to us that there's less of a genetic contribution to bipolar disorder in later agent onset bipolarity. The estimated heritability of bipolarity is estimated about 75 to 80% genetic. Mm-hmm. In older agent onset, it's considerably lower. That sort of feels right to me. Yeah. And secondly, they have more vascular disease in the brain, suggesting maybe that played a role in causing and unmasking the bipolar. So those are two features that immediately jump out for me.
Okay. Well, because we're dealing with this over 50 population for the female side, how does menopause come into play, or hormonal fluctuations? And also, how does it play into age-related brain fog?
In a big way. So, for example, we know that the menopausal transition for some women indeed is the first time that they declare an episode of bipolar disorder. There's no question about that. We've long known that the menopausal transition may be a time of risk for recurrence for women who already have declared bipolar disorder earlier in life. That's long been known. But what's also now known is that could be a time of heightened vulnerability for the very first episode. The second part about that, which I think is really, really relevant, is that during that time, and women going through menopausal transition know this well, and of course, I think it's generally known, are very susceptible to having, among other symptoms, hot flashes. Now, hot flashes themselves can interfere with sleep, but the other aspect that can interfere with sleep is something really interesting. There's an area of the brain in the hypothalamus. We won't get too lost in the weeds here, but there's a little area of the brain, hypothalamus. It's a part of our brain. The hypothalamus is the part of the brain that regulates all of our cycles. Mm-hmm. And bipolar disorder is a disease of cycling. Moods and your rhythms are off and so on. So what part of your brain is the rhythm center? It is the hypothalamus. Okay. And so with that in mind, if we look into the hypothalamus, there's a set of brain cells there. They produce a protein. And that protein being produced is responsible for being vigilant, being normally sort of appropriate, aroused, to sort of be aware, to be awake. And that protein is regulated by estrogen.
Mhm.
And when estrogen levels drop, as they do during menopause, it's a bit like the school teacher going on holiday for a week. What happens to the class? It goes out of control.
Okay.
And so what happens is that those neurons, those brain cells go a little out of control, and they then become over aroused, overactivated, just like my metaphor of kids being a little bit, horsing around when the teacher's not around. And so what happens is that also causes sleep problems. This is all to say that in bipolar disorder, it doesn't matter who you are, it is absolutely essential to have good sleep hygiene, good sleep quality, good sleep duration. And we know that this is a fundamental problem for many people. And when it is affected negatively one way or the other, they can't get to sleep, they're missing hours, they're jet lagged, that could precipitate mania or depression.
Mhm.
And menopausal transition is a very difficult time for women in general, not just women with a mental illness, but women in the general population. Sleep is a real problem for a lot of women. And it's not just the hot flashes.
Right.
Hot flashes play a role, but not the only issue. And for women with bipolar, that can be an exceptional problem. The other issue worth mentioning as well is that people who live with bipolar disorder have a much higher rate of obesity, especially the more sort of what we call severe obesity, that being a body mass index of at least 40 kilograms per meter squared, and much higher rates of diabetes type 2, and certainly much higher rates also of metabolic related problems like metabolic liver disease. So where am I going with this? Where I'm going with this is we did a study many years ago, and we found that women, especially older women, have even greater problems with diabetes. So this is all to say that not only is there the usual in the general population, unfortunately, as we get older, there are age-related diseases that we just begin to manifest, high blood pressure and weight and things like this. But those occur much more often, and they seem to affect women who are older more than men. So I think that there's aspects about sleep that are especially susceptible to women more than men during the menopausal transition. And during that time, we begin to see a significant elevation of other problems like metabolic problems, which affect women with bipolar more than men.
Okay. Well, I mean, there's so much of a correlation, even with some of the antipsychotics they may be on
Yes,
that
yes,
cause weight gain, right?
yes, exactly right.
So that as well.
Yeah,
Well, I guess my next question would be, for mania in older adults, um, it often mimics agitation or anger rather than that euphoria that you saw
yeah.
at 20 years old. I mean, how is that really different, and how do physicians identify that?
That's well put, and that's such a critical point you've raised. And if I could maybe step back a step or two, what I might say is that the way bipolar disorder presents is very much influenced by age. Now, again, there's not one size fits all. There's different people, and not everyone's the same. But you're absolutely right. When bipolar disorder first presents in the older years, after 50, after 55, after 60, the manias tend to be more like as you described, a lot of agitation, uh, a lot of restlessness. The person's quite restive and unsettled, often very dysphoric, um, just a very unpleasant feeling, terrible problems with sleep. Often family will describe their loved one as being quite snappy, quite irritable, in some case, even verbally abusive, frankly.
Mhm.
And to go along with that, what we also see is during that time, people are often describing a sense of gloom, doom, suicidality is reported at a very high rate.
Mhm.
And some might be saying, well, what is that mania? What is that? It is. We call it mixed. And you remember we talked about this before when we worked together that, bipolar disorder is type 1 is defined by mania. And for decades, mania was construed as a kind of a more narrow picture of elation and grandiosity and decreased need for sleep and spending sprees, poor judgment,
Mhm.
really rash and foolish business ventures. And that's still true, but that's also a very narrow description of the portrait of bipolarity. The great majority of people, especially older people, have this irritable, agitated presentation. And it's not uncommon, quite frankly, for someone who declares this illness for the first time after the age of 50 on the, either the encouragement or the threat of their family member, take them to a healthcare provider, and they think, oh, maybe you've got depression with agitation, or maybe you're anxious, or maybe you got early dementia. And,
Mhm.
and that's often, well, some of these diagnoses could apply.
Mhm.
But what's not entering into the differential diagnostic consideration is bipolar disorder. And I remember vividly when I was training as a fellow in I trained, this especially training in pharmacology before I was unleashed as a psychiatrist. And that is that I worked at a nursing home for a couple of years. And I remember vividly being asked to see people in a nursing home. Now, admittedly, that's a very different population.
Right.
Obviously, they have elevated needs and so on and so forth. But I remember being asked by nursing staff to see patients for agitation because agitation is
Mhm.
so common in nursing homes.
Right.
And I would see someone and I'd be sitting down with them, they'd be agitated. That wasn't the dilemma. But I then discovered that the reason why they were agitated is because they have bipolar disorder. And it was never diagnosed. And I was diagnosing bipolar disorder in some people for the very first time at age 65, 63, 71, and so on. So we can in fact see that more. Do we see that in people who are age 20 or 30 or 40? Absolutely, but not to the same extent we see it in people who are over the age of 50, 55, 60, who show for the first time.
Well, that probably is a very difficult presentation for physicians to see because I think I talked to you about this before. Like my mother, when she was dying, she was agitated and angry and
Mhm.
acting out in a way that she didn't act her whole life. And
Right.
I thought it was deterioration of her frontal lobe as she got older. And not to say that she had any diagnosis of bipolar disorder or any of those symptoms, but I could see where it would be very confusing for an average, maybe somebody who wasn't a psychiatrist, to see the subtle differences.
Oh, absolutely. And I always remind myself that in many ways, I may be a little harsh on myself, but I've sort of been I'm kind of a one-trick pony. I actually just been focusing on bipolar and depression my whole career.
Right.
And so, and I appreciate that clinicians in the front line are seeing dozens and dozens and dozens and dozens and dozens of different types of mental illnesses. So it's not easy, and often time is short, and the clinician has to arrive at a diagnosis, and also in many cases may not have the same level of experience seeing this population, and so look, they're busy. I think they're amazing what they do.
Right.
For me, it's all I do. So for me, these are patterns which I perhaps recognize a bit more easier, only because this is all I do, and so I would say that for me, and what's interesting is on this topic, I was just speaking about this recently at a conference, and that is that if I was to reflect out loud over the last several decades of this incredible privilege I've had doing this, I would say that what I have noticed, now what I've noticed could be idiosyncratic to me, unique to me. I don't think it is. I talk to people all around the world, they see the same thing. And that is, I'm seeing more and more people with bipolar disorder who are really irritable and really angry and agitated. We don't see the elation and the euphoria as much. I recall I used to see some folks over age 50 with bipolar who would have very classic elated euphoric mania,
Right.
hypersexual, hyperspending, this type of thing. And that was actually quite common, quite frankly, when I started my career. I don't see that as much. I see more of the irritability, the more agitation, the anger, well, I don't think we're really clear why that is. I've got speculations, but anyways, this is all to say to your point. It's easy to get diagnostically confused, diagnostically befuddled, diagnostically going down the wrong path. And diagnoses do matter
Right.
because the last thing you want to do is prescribe a treatment for someone with bipolar disorder that kind of amplifies the problem.
Well, now that we're going down this path, you touched on it earlier about patients that, as they get older, experiencing type 2 diabetes, heart disease. I know that you have done some research on the GLP-1s, tirzepatide and
Yeah.
semaglutide. And I wondered, right now they're really the rage, and certainly for myself, I tried it as well. But I wondered, what does it look like, and how are you utilizing these particular drugs
Hmm.
for mental health?
Yeah, that's a good question. And the way you finish it's critical. Currently, the GLP-1s, and I'll refer to them just as a class, there's differences across the agents and their FDA approvals are not quite identical and all that. So I'll just talk to them just as a general class. They currently have a total of 6 FDA indications. And the 6 indications, obesity, diabetes, metabolic liver disease, obstructive sleep apnea, progressive kidney disease and diabetes, as well as cardiovascular mortality and obesity. These are 6 conditions that affect bipolar at a rate much higher than the general population.
Mm,
So I start off by saying our patients usually have one or more conditions that are already on label for a GLP-1. In addition to that, clinicians have often prescribed GLP-1s to help assist their patients with bipolar and other conditions like schizophrenia to try to reduce the weight gain liability from some of the drugs.
mhm.
Some drugs like clozapine, which we use not infrequently in bipolar, but also schizophrenia, cause terrible weight gain. And people would say, well, if it's that bad, why don't you stop it? Well, we'd like to, but we can't. It's only treatment that's actually helped them. And so we have to stay the course. And so we use it for that reason. But the third sort of category is what you touched on, and that is, do they actually help mental illness? And the answer is we don't know for sure yet, but we got a lot of hope here. And there's 3 different kind of scenarios. One comes to mind is treating bipolar disorder. Can they treat and or prevent mania or depression? Second is, can they treat or prevent substance and alcohol misuse? And thirdly, do they have any effect on the loss of cognitive function over time?
Mhm.
And the answer is we just don't know for sure. We've got leads in each one of these categories that I just enumerated. I would say that tirzepatide has a sister, and the sister of tirzepatide is called brenipatide.
Mhm.
And brenipatide, like its sister tirzepatide, better known as Mounjaro Zepbound, brenipatide is a GIP GLP agonist. It's what they call a dual agonist.
Mhm.
And that one is now in phase 3. That's a phase 3 registration pivotal trial as a mood stabilizer in bipolar disorder. So
Okay.
stay tuned. We're going to see what happens. We'll have the results in the next, I guess, a year and a half, 2 years, maybe plus or minus. Secondly, in the area of alcohol, substance, tobacco, there's some really interesting data in the sense, especially alcohol. And again, remember, alcohol affects 30 million Americans have alcohol related problems, thirds of alcohol use disorder. And alcohol is very commonly misused in bipolar disorder. In fact, of all the mental disorders, bipolar has the highest rates of alcohol and substance misuse.
Mm,
So treating alcohol is really important all across the ages. And there's some data to show that GLP-1s as a class, each agent's slightly different, have a mitigating effect on heavy drinking and the number of days that you drink heavily and so on and so forth. So that's interesting. And third and finally, people who have bipolar, so this is critical to our conversation, over the age of 50, they have a higher risk for Alzheimer's disease and Parkinson's disease, both.
mhm.
And that risk seems to be mitigated in part by lithium. That's interesting. That's certainly very interesting. And there's been mixed evidence as to whether GLP-1s can help aspects of Parkinson's motor symptoms and or cognitive function deterioration in Alzheimer's. There's been some hits and misses on the studies. So we don't know yet. But that all being said is that there are indirect reasons why these drugs are so relevant to bipolar, being on label, FDA approved. There's
Mhm.
some other conditions that people are looking at with these agents for FDA authorization, but also are they psychiatric drugs? I've written about this extensively for a long time. And I guess ultimately we're going to find out in the next year to 2 years, maybe 3 years. But what's there looks very promising.
Right. I see such an impact just over on healthcare cost and, the
Yeah,
drugs seem like they're really, really great.
yeah,
Another topic that's in the news right now that everybody talks about, especially anti-aging, is inflammation.
yes.
So how does chronic inflammation, which is very common as we get older, affect the brain's ability to stay stable? Or does it?
It really is an important topic, and there's a portmanteau, a word that's made up of two words called inflammaging. Inflammaging, how inflammation is not just a byproduct of aging, but inflammation promotes aging. So it's both the cause and the consequence of aging.
Mhm.
And that's an interesting literature. And there's no question that when the brain and the body are exposed to inflammation, it does result in premature cellular aging throughout not just the brain, but other organ systems. And in bipolar disorder, there's been a pretty compelling framework that's been put together um, that has suggested that in addition to a greater likelihood of observing an increase in inflammatory markers in the brain and in the periphery in bipolar disorder. Along with all of that, there's also been some evidence, molecular evidence, by using biomarkers that there may be some premature cellular aging going on as well. So, for example, your molecular biologist can pick on a couple of the molecules inside your cells that kind of keep they're kind of your age. They can tell your age simply based on the anatomy of these molecules inside your cells. And they have shown that there is premature cellular aging at the molecular level happening in bipolar. And there's already clinical evidence of this. In other words, if you lived a healthy life, don't smoke, don't drink too much, exercise, get sleep, live a good, healthy life, and you're of normal body weight, well, guess what? You get older. As you get older, things start to happen. You start to get blood pressure and cholesterol and triglycerides, your lipids go up and all this
Yeah.
stuff. Anyhow, that's just part of aging. And bipolar disorder is associated with a shorter health span, meaning those conditions that you would typically think about in someone who's maybe 45, 50, 55, 60, those conditions are not uncommonly seen in people who are 25 or 30 or 35.
Mhm.
So you have a premature onset of many so-called age-related diseases in bipolarity, which probably is the clinical manifestation of the molecular aging process. And secondly, dementia, which of course is part of aging in the general population, occurs not only at a higher rate in bipolar, but also at an earlier age. So there's that truncated age again. So
Right.
far, this sounds very dire. I don't want to sort of leave people with this sort of gloom and doom kind of notion. I don't want, that's not the point. The point is that these are the facts we're dealing with. But the good news is that if you can detect, diagnose, and treat bipolar timely and accurately and go on appropriate treatment, we've got lots of evidence to show that you can reverse much of these processes very quickly. So now I'm not here to say you can turn the whole ship around in everybody overnight. I'm not saying that. But what I'm saying is that a lot of these observations that have been made are very much fungible. They're very much malleable, but it's contingent. It depends on getting diagnosed and treated.
Right. Well, there's so many people that are older that are polypharmacy, that get prescribed so many different
Yeah,
drugs. And I
yeah.
really wonder, how does that impact their cognitive clarity?
Well, there was a paper that I read about a year or two ago. It was in the American Journal of Psychiatry and one of our, leading journals in psychiatry, medical journals. And what investigators did was and this wasn't just in bipolar or in an older population, but it's really relevant to your question. They took people who were taking a category of drugs called anticholinergics.
Hmm.
And for your listeners, anticholinergics are drugs that block the acetylcholine system, and they're used for a bunch of purposes in medicine. They're in a lot of cold and cough medicines. They're in a lot of prescription medicines. We use them to treat different conditions to offset the side effects, and we use them as anti-nausea. I mean, they're kind of like a Swiss Army knife. They're used for almost everything in medicine, frankly.
Mhm.
That's all to say they're not quite in the drinking water, but they're just basically everywhere.
Right.
And what these investigators reported was really interesting. They reported that when they tested the cognitive functions of these people, it was impaired. And we knew that would be the case because anticholinergics can interfere with cognitive functions. But when they stopped the anticholinergics, there was an improvement in their cognitive function, no surprise. And
Right.
that improvement was of a huge magnitude. So, 2 points. One is yes, we do have a lot of polypharmacy, especially in people over the age of 50. Second is that some of this polypharmacy is redundant. Some of it is countertherapeutic. In other words, one drug's trying to increase the function of a receptor, the other one's decreasing the receptor. We see that not uncommonly. And in some cases, it's completely and outright harmful to the patient, interfering with cognition. I can't think of an example more than the elderly, often on benzodiazepines, often multiple benzodiazepines, taking a lot of sedating drugs. Antipsychotics can be sedating, anticonvulsants can be sedating. In addition to not only interfering with cognition, it can contribute to instability of, their gait, their posture. They could fall down, break a hip,
Right.
this type of thing. And so taken together, there's no question that we have that. Now, if I lived in the perfect world, if you lived in the perfect world, well, bipolar disorder could be treated with nothing.
Mhm.
I guess the next perfect world would be, could it be treated with just one medication? And I wish it could be. It rarely ever is.
Right.
So the reality is that if we're treating, let's say, diabetes, many people with diabetes need insulin and they need a GLP-1. They're on two drugs.
Hmm.
And that's the best way to manage it. And for bipolar disorder, they need to be on more than one medication. It's just the way it is.
Right.
And we need to recognize that, and that's just the way it is. That being said, there's no question that in my career, I have found myself having almost as many successes by taking people off of medications that they shouldn't be on, that are contributing to their cognitive problems, making them sedated, affecting even their mood states, et cetera, so forth. So I think that's really an important message. We need to kind of almost sanitize the regimen that they're on. Just recently, on behalf of the ASCP, good colleague Joe Goldberg in New York led a group of us and published a deprescribing guideline. And to be clear, what we're not arguing on behalf of the ASCP is that people should be off medications. That's not the gist. The gist is they should not take medications they don't need, which I think everyone agrees on. And secondly, they should not take medications that are not making sense. You could be saying, well, give me an example. Well, I see a lot of people who are taking drugs to boost their acetylcholine system to help their memory, and they're also taking an anticholinergic. That doesn't make any sense to me. And why would you do that? Or they're taking a stimulant. A lot of older folks take stimulants because they think it can help their energy, their motivation, and their cognition. At the same time, they're taking two benzodiazepines and two sleeping pills. Okay, so right, so I see this all the
Right.
time,
Yeah.
all the
Yeah.
time.
Yeah. Yeah.
And so that clearly has got to stop. So, and that's what we tried to capture in the deep prescribing guide. But I'm glad you start off that way because people often say to me, "Hey, what's the first thing you would prescribe for this person or that person with bipolar?" I said, "Whoa, whoa, whoa." The question starts off with, "What would I first deprescribe?" And then I move on to what I would prescribe. Yeah,
Yeah, yeah, yeah. I agree.
yeah.
Out of all the physicians, psychiatrist's office that I went into, I heard about elderly people and benzodiazepines. I
Oh,
mean, every single they go, oh, please don't try to get my patients off of their benzodiazepines. We'll have tears in the office. So I heard that a lot. Okay, so there's since we're kind of going down the road of things that are in the news and people are talking about, what about ketamine?
yes. So ketamine is interesting. It goes back to 1962, in Detroit at Wayne State University. A guy called Calvin Stevens discovered it. And of course, everyone knows it in the world of anesthesia. Back in the year 2000, it was first demonstrated in controlled trials to be an antidepressant. And this is a drug that I think has been transformative in treating bipolar depression, especially the depression with lots of irritability and what we call mixed features,
Mhm.
agitation, anxiety. I call it the four A's: anxiety, agitation, anger, and attentional problems, all occurring while you're depressed. And what we have found with ketamine is A, it's safe, B, it's well tolerated for the most part, C, is that we don't find ourselves getting into any problematic side effects with it. On the good side, those are all goods, but we don't want to harm people. So we start off with that. The second thing is it works very rapidly, and it works in people who've really had difficult to treat conditions. So we've done this in people, 18 to 65, but 65 and older as well. And Spravato is one of the marketed formulations. It's an intranasal formulation. That's ketamine. That's also available, also used in the elderly. Now we're talking about bipolar depression, and some people might be thinking, "Hang on, was it approved for bipolar depression?" No, ketamine's generic. It's not approved for any mental illness, well, specifically mood disorders. It's used off-label. And the S-ketamine, which is the proprietary Johnson & Johnson product, is actually approved in major depressive disorder, not for bipolar disorder. So this is off-label. Does it make people manic? No, not usually. Does it make them more psychotic? No. Do they have more dissociation on it? No, not at all. It's very safe, and we're getting very nice results. And over the years, what I have found is as people do get older with bipolar disorder or bipolar begins later in life, I have found the depressions especially more difficult to treat. So we go through the FDA approved treatments for bipolar depression. Unfortunately, there's only 5 of them, and we can exhaust that list pretty quickly, unfortunately. Patients don't want to gain a lot of weight, so they don't want to take 2 of them right out of the gate. So that leaves us with only 3 of the FDA approved agents: cariprazine, lurasidone, and lumateperone. And so, unfortunately, we go through those 3 pretty quick in many patients. For many patients, those drugs do the trick, but for many, they don't. And we need to do something different. And ECT is an option, but ECT, thanks to Jack Nicholson, has a bad public relations, bad PR. And anyhow, that's all to say that Hollywood has a certain depiction of ECT that's a lot more sensational than it truly is. But
Yeah.
ECT doesn't do too well in public relations, but it's a fantastic therapeutic. So people say, I'm not going to go for ECT. I don't want that. I wish they would more than they do because it's very safe and very effective. But ketamine has certainly been one that I have found in my career has been just transformative for patients.
Okay. Well, that's good to know because again, we had a celebrity die from a ketamine overdose,
Yes,
and
yeah.
people relate to that don't, know what ketamine is indicated for.
That's right. That was obviously a huge tragedy and probably a story more of criminality and inappropriate behavior than it is about the therapeutic opportunity of ketamine. Of course, these things all get mixed in the same narrative.
Right.
It's unfortunate. Yeah, ketamine has been life-saving for people. And the other part too, I didn't mention, which I mean I should have. My goodness, just a couple of weeks ago in JAMA, the Journal of the American Medical Association, my colleagues and I published a paper showing that ketamine rapidly reduces suicidal thinking
Mhm.
in people. And again, suicidality is not a mental illness, but suicidality is a obviously very serious behavior and thought process. It's a thought process, often followed by behavior, that probably affects bipolar disorder more than any other psychiatric disorder. And so it's serious. And the fact that we can rapidly, what does rapidly mean? In a few hours, maybe one day,
Oh,
alleviate suicidal thinking, that is huge. And a
right.
lot of people say to me, well, did you reduce the suicidal behavior? Did you reduce suicide? We don't know yet. And they'll say, well, what's the big deal just reducing suicidal ideation? I would say, have you ever been suicidal before? That's a big deal, okay?
Yeah.
And that's a huge deal. And second, for a lot of people, it's all they know. And for the very first time, they're no longer suicidal. It gives them a whole new perspective of life. And so I would never minimize the importance of reducing suicidal thinking. And I've had this conversation with so many colleagues around the world. So
Right.
anyway, so I just proactively say that.
Yeah. Well, good to know. Well, we're coming down to the end, so I have two
Yeah.
more questions
Yeah.
and then we'll wind it up because you've been so gracious with your time. But if you would think about cognitive health and longevity,
Yeah.
what were the red flags that would tell you that a patient's memory issues were from bipolar and not the start of Alzheimer's?
I think that the telltale sign is really the speed of the cognitive loss and the timing of the cognitive loss, insofar as the cognitive loss of bipolar is certainly real, it is progressive, but it tends to be a slower but insidious process. Alzheimer's or other major neurocognitive disorders, when they manifest, yes, it can be insidious. That is a kind of a slow developing process, but it tends to be a bit more rapid in its pace. There
Mm.
are other features as well, the type of cognitive impairment that also tells us a bit about the condition, of course, family history. So for me, the cognition loss that leads to functional impairment directly that looks like dementia is if it's slower, it's more bipolarity, a little faster is how it is in Alzheimer's.
Okay, good to know. And then the last question that would be on a high note, beyond just stopping mood swings, how can older patients regain their sharpness and maybe their workplace productivity?
I think there's a lot of literature now to show that social engagement and or disengagement and loneliness is a major problem. And the elderly tend to be more socially isolated and as a consequence are more susceptible to loneliness. And loneliness can accelerate cognitive impairment. We saw this during the pandemic in the general population. So as they say, if you don't use it, you lose it. So I think you in fact want to be engaged. A lot of people don't have friends and family. They've left the workforce, family members have passed away, but there's other types of ways you can connect with animals, arts, your community, nature, and so on and so forth. That is really important. We have a lonely planet right now, and I think this is really important. Second is the usual sort of lifestyle habits of exercise to the extent you can, and of course, diet that's affordable, and of course, adequate sleep. And no one can ever overemphasize the importance of that. I think the other point I might finish on is that because people get older, they are more susceptible to conditions that can affect their cognition and function. And this is why it's so important in bipolarity to manage what I say above the neck and below the neck. You want to manage bipolarity, the depressions, the manias, but you also want to make sure that your diabetes is well controlled, your thyroid is well controlled. Try to keep the weight within as close to normal weight as you possibly can, and also some other conditions like heart disease and liver disease. Here's a statistic: 40 to 50% of people with bipolar have metabolic liver disease. 40 to 50% don't even know they have it, and that can affect their cognitive functions. And so they could talk to their clinician, hey doc, hey nurse, do I have metabolic liver disease? It can be treated. So we treat these secondary causes. But again, I want to go back to how I started. I think this is a lonely, lonely world. And I do think engagement in social prescribing is as important as is the pills, as is the manualized psychotherapies.
Well, you're everybody has that I have interviewed. I interviewed the head rabbi at Cedars, said the same thing.
Oh,
Community,
wow.
community, community.
Oh,
That you have
100%.
to treat the whole patient. Even
100%.
my Tai Chi master that I interviewed said the same thing. It's like
Okay.
you have to have community, so it's a very interesting thing. So we're going to leave all of the people out there today with think about creating your community and staying active and engaged.
100%. Thanks for
Anyway, Doctor, you're the best. Thank you so, so much. And I hope to talk to you again soon.
me too. Fun doing this, and thanks for having me.
My pleasure, Doctor.